Hello, everyone, and welcome to today's webinar, Medicaid in the Nonprofit Arena, Funding Threats and Reform Opportunities. Before we get started, I want to go over just a few items so you know how to participate in the webinar today. When you joined, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing the audio pane in your control panel. You will also have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of your control panel. You can send in your questions at any time, and we will collect those and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grant Makers and Aging and the moderator for today's webinar. John?
Thanks so much, Emily, and thanks to all of you who have joined us today. I'm glad that we have so many of you who are able to take time in beautiful summer weather here to be with us. Before we begin, I want to thank West Health, whose support allows us to offer this webinar free of charge to our members. As you know, this is a time of rapid and sometimes bewildering change in Washington, and programs in aging are part of that change. GIA, as a membership organization, is trying to better serve its members by providing these monthly webinars with experts from the field. Each of them represents their own organization's point of view, but they are experts who are working on the ground directly every day on these issues, so they're very well aware of all the changes that are taking place. As Emily said, today's webinar is on Medicaid and the nonprofit arena, funding threats and reform opportunities. And obviously this was a very interesting week for this particular conversation with all of the changes and not changes that took place in the legislative arena. We're extremely happy to have with us one of the Washington insiders that we rely on for information for this, Jonathan Weston, who is Senior Director of Health Initiatives at the Jewish Federations of North America. And just a reminder before we get started, as Emily mentioned, you can enter your questions at any time in the question box that you see on the screen. And please start doing so at any time, and we will turn to those just as soon as John's finished with his presentation. So Jonathan, great to have you with us. And why don't you walk us through the complex and ever-evolving material that we have in front of us here.
John, thank you, and Emily, thank you for your coordination of this. It's a real privilege to be here today, and an honor for JFNA to be one of the members of Grant Makers and Aging as well. We truly cherish our membership and our time with the fellow members, and it's particularly important, I think, to note that despite the generosity of so many of the foundations that are members of the Grant Makers and Aging, there is simply no way, should these cuts go through that we're going to delve into here in Medicaid, that your foundations will be able to cover the losses that we're looking at in perpetuity, particularly for arguably the most vulnerable and costly population that Medicaid covers, and that is the population, of course, of older adults. So Emily, if you could advance to the first slide, please. We're going to do this in three different areas. We want to go over just for a little bit our Strategic Health Resource Center here at the Jewish Federations of North America, so you can kind of get a little orientation of who we are, what we do. Then we really want to spend the bulk of our time talking about the threats to the healthcare safety net, principally Medicaid, but since Medicaid is so large, go over a bit of what it touches, and also what the reading of the tea leaves might be in the coming months as we head into fall and the winter work periods. And then we'll finally end on what you all and your boards might do and your communities might do to take action. Next slide, please. So our Strategic Health Resource Center was founded in 2015. This was at a time of major transformation for the healthcare system of the country, basically because it was in the throes of the implementation of the Affordable Care Act. There were repeal efforts at the time. I think when the SHRC was founded, we were, I believe, at number 35 of the repeal bills that had made their way through the House. Some of those had even passed the Senate, but repeal was really not taken seriously, much as some would say, like the 45th president's candidacy, until the votes were in and people realized what we were looking at. Reality sunk in. Now we had, for the first time in 6 years, a truly unified government that could make strong change, and there was such visceral reaction in so many camps to repealing the Affordable Care Act that we assumed this would take a matter of weeks, not months. So we had to change our focus and our game, if you will, to really look at and assess the consequences of what a repeal would look like for the Affordable Care Act, but generally how that repeal might impact Medicaid itself. And it's interesting to note that when we first started talking about the consequences of cuts to Medicaid, we used as a benchmark 10% as a number. As you'll see later on in this presentation, that number has advanced to about 35%. But our mission overall is to preserve the ability of Jewish communal health, behavioral health, and long-term care providers to serve as a critical health safety net. So we're not unlike, if you will, Lutheran Services of America or Catholic Health Association. We are a faith-based provider, but clearly we are serving people of all denominations, creeds, and colors. And for us, it is just vital in this office where I'm speaking to you now that we have as robust provider rates as possible, as we have the most flexibility as we can among government programs so that our providers can innovate, and that we are able, if you will, to partner and invest with government dollars to make the right choices moving forward. We'll get into some of this later, such as accountable care organizations, or a bit closer to home for this crowd, aging in place initiatives. Next slide, please. So we have about 148 federations and 300 smaller communities, places in Alaska, Wyoming, what have you. Most of our focus, though, is in very, very large cities, and our providers in those cities would be 15 leading academic medical centers, which used to be Jewish hospitals, but now they've really expanded, to places like Mount Sinai School of Medicine in New York or Cedars-Sinai of Los Angeles. We have 100 Jewish aging communities. We used to, in generations past, we'd call those rest homes. Now, of course, that would be a terribly outdated and unfair characterization. They have assisted living facilities, independent living facilities, home and community-based services, and of course, skilled nursing facilities as well. And we have Jewish family and children's agencies, which number around 125, which specialize in home care, community mental health benefits, as well as even some community health providers as well. Next slide, please. So our core policy priorities in many cases are shared by most of you. We want to protect and strengthen our healthcare safety net, which the two key pillars are Medicaid and Medicare, and it's very purposeful, of course, that those two are married together, because one of the populations which is overlooked, discounted, and not taken as seriously as it could in the way of efficiencies, cost savings, but also in innovation, is the dual eligible population, something that we frankly are obsessed about here. And there are over 9 million dual eligibles now, and that number will explode given the aging of the boomers. We care strongly about healthcare transformation. In fact, I met last week at length with Dr. Mark McClellan, one of the founding fathers of the accountable care organization model. We had a one-on-one meeting to discuss how we can partner with him on expanding the ACO models. Many of you are familiar with Dr. McClellan, who served with distinction as President George W. Bush's administrator for Medicare and Medicaid. We are very dedicated to seeking long-term care financing solutions where we can. I know my good friend and the previous presenter on these webinars, Ben Vecti of the National Academy of Social Insurance, where I'm a very active member and engaged member, served with me on something called the Long-Term Care Financing Collaborative, which I co-chaired along with Stuart Butler, formerly of the Heritage Foundation, and Howard Gleckman of the Urban Institute. So there are many of these panels in town, beginning with the Pepper Commission in 1989. We have so many ideas, many of them overlap. There's very little disagreement on what needs to get done. There is simply a lack of congressional will, regardless of who is in charge. And if I can editorialize for a moment here, there are many words spoken in Washington. One of the words that is seldom spoken, though, is investment, and you're going to need investment in this area to move it forward. Advancing the behavioral health system is key, and the area where we see exploding growth in behavioral health is in the older adult population, given a lot of comorbidity issues. And particularly, our work is quite noted in the community, as many of you know, on easing the strain on family caregiving or family caregivers, particularly increasing respite initiatives. Next slide, please. So now we get to the threats to the healthcare safety net itself, and we see a poor soul who has fallen into that safety net. Next slide, please. And you know what we have here is we have the triple threat, one of which actually we kind of felt. I was actually going to take this bullet point out 2 weeks ago when I started drafting this, and I had to put it back in. This business of repeal, outright repeal, because that was really never in the cards. The American Health Care Act, or the Better Care Reconciliation Act, as it was known in the Senate, that was all about really amending the Affordable Care Act. That was the Republican attempt to fix the Affordable Care Act. I'm just using their vernacular, not mine. That was extremely objectionable to the conservative wing of the party, led by Rand Paul. So now that the BICRA has blown up, as you've all seen in news reports over the past 36 hours, Senator McConnell yesterday, the majority leader, began a full-throated effort to repeal the Affordable Care Act outright. That initiative looks like it's dead in the water because he has 3 Republicans against. Those 3 Republicans, incidentally, or not so incidentally, 3 female senators, very outspoken, who were pretty angered from the beginning, arguably rightfully so, that they were shut out of the 13-person working group of all white, all male senators that constructed the Better Care Reconciliation Act. So that's repeal and replace. Clearly for us, our obsession, to put it lightly, are Medicaid block grants and per capita caps. That's really what we are what we've been focusing on this year. And then finally, we have the CHIP program, which for us and some Medicare extenders, which we'll be able to get into. Next slide, please. So currently right now, pre-ACA, this was, sort of a comical take on cost containment here. But, it's about, what we can offer in the way of a healthcare plan. Comically, as you can see here, this is a HR person saying, congratulations, you have a job offer. Instead of a healthcare plan, here's a tough guy named Lou. He's just going to persuade you not to get sick. Next slide, please. I don't really want to have to explain New York cartoons to all of you. I think you're pretty savvy about all that. We're going to really breeze through these slides here because so many of you are so familiar with Medicaid and what Medicaid does. So Medicaid was founded 52 years ago, July 31st, 1965, along with Medicare. This is a word I hate that I probably should have adjusted here, an entitlement, meaning anyone who meets the criteria has the right to be covered. It really is a vital social service program, and entitlement is a word that we're trying to get away from because if you paid into it and if you qualify, of course, you're going to get it. It is the only large long-term care insurance program for low-income Americans, and it is emblematic, if you will, of market failure. The long-term care partnerships have failed. Long-term care insurance policies in this country, the market has imploded. Long-term care is an issue where it's very, very difficult to save. All of these are very important factors when you take a look at how Medicaid growth has mushroomed. Now, this is important because when we take a look at many of the Republican leadership's comments on Medicaid, one could argue that they're absolutely correct. Medicaid is not sustainable moving forward, but it's not sustainable because there has been this market failure. So the reaction, at least in JF&A's context, is not to aggressively cut Medicaid by 25% or 35%. The reaction clearly is to reform the programs and offer additional options for long-term care. Next slide, please. So what you have here is you have the federal share for Medicaid and you have the non-federal share. So on average, 57 cents of every federal dollar or every dollar in Medicaid is part of the federal share. 43 cents is the state share, if you will. This is traditional Medicaid. What do I mean by traditional? This is a very important contextual point that I really want to make for you all for our time together. Traditional Medicaid, for me, extends pre-2010. It began in 1965 with the founding of Medicaid. Medicaid expansions are different. They're different because not every state has a Medicaid expansion, number one. Number two, the Medicaid expansion piece of the pie looks far different. It is a 90-10 split. That means that 90 cents of every dollar comes from the federal government to cover those state expansions. Only 10 cents of every dollar comes from the states. That's a problem. That's a problem because it is not sustainable in the long term, and it's a problem because it has given fodder to many conservatives and many respected reformers in the Republican Party, such as Bill Cassidy, to say that the current Medicaid reimbursement formula, I'm using his word, not mine, but it's a word widely used in Republican circles, is perverted. Medicaid itself, the reimbursement rates right now are perverted because of a 90-10 split, particularly a 90-10 split going to healthy, able-bodied adults who simply need insurance coverage, not going to those who are older adults or those with disabilities who in most states or in many states were reimbursing at 50 cents of the dollar, like New York, Illinois, California, and such. All right, there is an argument to be made there. The conclusion that Mr. Cassidy has, with all due respect to himself and many Republicans, and the conclusion that we at JFNA have are a bit different. Cassidy says just cap the entire thing or block grant it. We say no, reform the program. Next slide, please. All right, this is just unbelievable. 1/4 of the U.S. population right now is under Medicaid. 80 million Americans. We're about, according to the 2017 population table, we're about 324 million Americans in this country. 80 million people are on Medicaid right now. That does not mean that these are 80 million people who have transferred their assets or 80 million people who somehow, some way are executing fraud, waste, and abuse. It means that many of them have witnessed market failure. It means many of them are unable to get insurance through other means. It means that many of them truly are destitute or poor or meet certain income thresholds or just could not get access through other areas. So I take a look at 80 million people. I see that many of them are in this from a vital social safety net standpoint. I also see that many of these 80 million people, this society, our society, has failed them because we have not given them, if you will, many middle-class exit off-ramps, if you will, to require insurance or coverage in other means, whether that's health insurance or long-term care. Next slide, please. So this is just a pie chart real quick of who Medicaid serves. And you'll see, shockingly here, just take a look at the blue color here, 48% of all Medicaid beneficiaries are children. Children, it is not CHIP. CHIP only serves 9 million kids. CHIP is basically for working class children. Medicaid is for destitute children. So when you talk about what we're going to cut those, all those kids. Now, adults are and the older adults are only 9%. 9% seems like chicken feed, but when you take a look at the expenditures on those 9%, particularly the old, we'll get to them in a moment, that's a lot. Next slide, please. So, I think you all know where we're going with this. We all know how Medicaid works with older adult populations. We all know that Medicaid itself and the older adult populations, there are a lot of choices to make here. There is a lot of spending on them. The fact now that almost 1 out of every $5, that's where we're heading in this country, 1 out of every $5 is a Medicaid a healthcare dollar spent. That is stunning. That's mystifying, and that should, you should lose sleep over that, because we are still at a place in our society now where the boomer is healthy. You fast forward 20 years where the boomers are between 72 and 90 years of age, or 91 years of age, respectively. We've got some issues. Next slide, please. So here we get down to those boomers, and we get down to the fact of not only are they aging, not only are there roughly 78 million of these boomers moving forward, but these boomers themselves are clearly not save or position their finances better than they did for their than their parents did. This is not the Depression era boomer that we are looking at right now. So this is, or the Depression era individual, I should say. So as a result of that, they are less positioned. They've had less access to affordable long-term care insurance policies. Healthcare costs have gone up. So we got problems, and we're not talking about, again, lasting reform or implementing that reform that many commissions have come up with. Next slide, please. So here we are on LTSS and Medicaid. 1/4 of Medicaid enrollees are low-income older adults or adults with disabilities. And when it comes to nursing home services for age 21 and older, we've got about 1.7 million people. This is current figures. So if you extrapolate what this is going to mean in the next, decade or two, we are looking at a much more higher amount, not just of a population, but higher amount of costs if we cannot contain these costs. And right now, again, Medicaid is incredibly institutionally biased in many of these different counties and states. Next slide, please. Okay, thank you. So by 2026, the boomers begin to turn 80, and the older adults will cost about twice the amount as the rest of the Medicaid population. I believe the older is about 85 years of age and moving up. And we will expect a plethora of the older adult in the next 10 years or so with the advent of the boomer reaching that. Now, those deep-set cuts, which we're going to get to in a moment, they begin around 2025, but they get really ugly following that. Next slide. Okay, so a couple of other things. I mentioned earlier this sort of kinship between behavioral health and older adults and what we're seeing. So whether or not it's opioid addiction, whether or not it is dementia, whether or not it is the pressure under accountable care organizations and other types of health delivery modalities to have step-down units, we're seeing a lot of post-acute or a lot of acute facilities moving their patients with behavioral health issues into post-acute facilities or skilled nursing facilities. That is only going to grow over time. So we're going to really have to address in very sensitive ways, but also very strategic ways, behavioral health and its growth among older adults moving forward. And it's not just opioid addiction that a lot of these senators, frankly, and representatives should be concerned about. That is a major issue. I don't want to denigrate it, but it's also prescription drug abuse overall and what we are seeing there in many ways, shapes, or forms. Okay, we can move forward, please. So people with disabilities account for about 15% of the Medicaid population. That's 10 million people currently. And this is, again, an emerging source of folks. People with disabilities are living longer, and there is a strong, uniform, and very meaningful desire for people with disabilities to be as much a part of the social fabric of our society as possible. To date, to marry even, to get a job, to be active in the community civically. These are things that were either unthinkable or very rare a generation or two ago. Organizations like ours are very vested to make that happen. But in order to make that happen, many people with disabilities who are on Medicaid are looking to Medicaid to be more flexible in their programmings or their program offerings, particularly when it comes to personal aids and ensuring that those personal home care assistants, for example, can be there in time for them in the morning to get ready to go off to work. This is only going to grow in demand moving forward. However, the argument being made by people, by the disability community, is a very valid one, that if they have these supports, they're able to contribute to the tax base and grow our economy. So it's very intriguing, it's very meaningful, and it's where we are as we next week, believe it or not, approach the 28th anniversary of the 27th anniversary rather, of the Americans with Disabilities Act. Next slide, please. Okay, so we're getting in now to some of the comical, I find them comical quotes because I just don't find them in reality right now. But there is a certain view by the new administration, by Congress, of Medicaid as a cash cow, that we can somehow, some way cut aggressively the Medicaid program and use those money for tax cuts for different populations, primarily wealthy populations, and frankly give the rest to middle class for subsidies to buy insurance on exchanges. There is not one credible report that has come out that has substantiated the plans by either the House or the Senate, number one. Number two, the reports that have come out, like the recent Avalier study over the weekend, for example, which was commissioned by the National Governors Association, one of the most bipartisan groups in America, to assess what the Medicaid cuts would be in the Senate legislation. It came back with deep cuts. Avalier said you're going to have deep cuts. When the Avalier report was presented to Secretary Price and Seema Verna, the CMS administrator, at the governor's conference, Price and Verna basically discounted the report and said, don't worry about that report, trust us, we'll figure out some way to subsidize this money moving forward, just throw your support behind the Senate bill. Obviously, the governor has viewed that in quite a dubious manner. And you see, I think, where we're going here. Block grants to Medicaid, block grant to Medicaid to the states, so people who are closest to, people in need are really administering it. I mean, it doesn't really make much sense. Paul Ryan talking about dreaming of cutting Medicaid at a cake party. A budget initially proposed by last year by Tom Price calling for $900 billion in spending reductions to the Medicaid program. We're really moving in the opposite direction here. We're not moving towards more flexibility in Medicaid in the way of home and community-based initiatives. We're not moving towards investing in the program to reform it. You don't reform a program by aggressively cutting it. You reform it in some cases by adding money, or at least having a cost-neutral program, and looking at different ways that you can innovate that really rest on best-case practices. Move on, please, if you can, Emily. Thank you. So just a key difference here. A block grant is a fixed amount of funding, regardless of the number of Medicaid beneficiaries or healthcare costs that increase. And number two, the per capita cap is a fixed amount of federal funding per beneficiary, regardless of unexpected increases in healthcare costs. So, for example, it's either an epidemic or a difficult to treat condition or more expensive, new treatments. So, that really is where we're going on this right now. There are two different ways of doing it. The per capita cap we define as block grant light. It is very, very hard to ascertain once you're locked into a per capita cap when you have a natural disaster, when you have an economic downturn, when you have even a confluence of both, how things will shake out. And the case study that we have been using on the Hill quite repeatedly is Puerto Rico. Puerto Rico, this gleaming resort, has been under a block grant situation now for several years. And they just declared bankruptcy in large part because they had a block granted Medicaid program. Why did they have to declare bankruptcy? What happened in Puerto Rico? Frankly, a mosquito. A couple of mosquitoes, and that was the Zika virus. Zika came in, it infected women who were pregnant. They had now, healthcare issues, very complex healthcare issues that drove up costs. The women gave birth to children who had very complex encephaly and healthcare issues, and hydrocephalus in some cases. And then the tourism industry dried up because nobody who was coming down for a family vacation that was of childbearing age wanted to go to Puerto Rico given the Zika epidemic. So when the major industry of tourism started drying up, all the jobs traditionally related to that industry disappeared. So able-bodied men generally left Puerto Rico. They went to the mainland because they're citizens. And as a result, who was left in Puerto Rico? Women caring for children. Able-bodied women left, I should say, who did not have children or were able to move with older children. So who was left? People who needed support. The older, people with disabilities, and women with young children, in some cases now, children with profound illnesses. Move forward, please. Emily, thank you. So these are some of the threats, right? Flexibility, waste, fraud, and abuse, waiting lists. These are some of the things that, when we take a look at proposals The canards coming from Republicans are such that what we find is well, Medicaid is not flexible enough. Medicaid has too much waste, fraud, and abuse. There are way too many waiting lists on Medicaid. We can fix it. You're not going to fix any of these things with a Medicaid issue, with a Medicaid cut, as you're looking at right now. You just simply will not do it. So that really is a key challenge right now. The more you cut, the less you invest in the program. It's a real risk. And we already have flexibility. We have waivers. We have efficiencies that are already adopted. We have, a fairly low administrative cost in the system. We have ridiculously low provider rates, and I can bring up a bunch of different providers within the Jewish network or other networks that would testify to that effect. And we have a slower rate of growth than either the private sector or Medicare. So it is stunning that Medicaid, with these factors, particularly that slower rate of growth, is the program that, for lack of a better term, is being picked on. And that is where we're at right now. There are no cuts to Social Security in this budget. There are no cuts to Medicare in this budget. But there is this massive cut to Medicaid. Next slide, please. So I think we've talked a lot about this. Under a cap, there would be no federal entitlement. Medicaid would be catch as catch can. The states would be empowered to make draconian choices of, do we cover optional populations like home and community-based services? Do we cover nursing homes and older adult populations? What do we have to do? Oh, and by the way, are there certain mandatory populations? Let's say, for example, the early prevention, screening, diagnostics, and treatment for children, which is one of the most popular and cost-efficient programs. Do we just sort of give that up? And will we be empowered to give that up? Most signs from HHS say that, yes, you would be empowered to give that up. You would literally just have a program that is no strings attached, just a chunk of money that would go to the states with very, very few limitations. And on top of it, any of the economic models that were done by the Congressional Budget Office show that Medicaid itself will not keep pace with healthcare inflation. So over the years, this is where these cuts come in. These cuts don't come in tomorrow. If any of these healthcare laws are signed in today, they come in over time. And that's where you get, for example, in the BICRA, the Better Care Reconciliation Act bill in the Senate, that 35% cut in the year 2035. So the boomer on the cusp of turning 90, the eldest boomer, Medicaid at that point will be cut by 35%, more than a third. Next slide, please. So again, we're going to be shifting substantial costs and other burdens to the states. If the states want to make up the difference of these massive federal cuts, that the states will, they can be our collective guests to do so. However, of course, with virtually every state under a balanced budget, it is highly unlikely that states are going to be able to make up the difference. Provider payments, I think I was a bit generous in this slide, could drop. Provider payments will drop. In fact, you're going to have issues even finding providers who will still be able to take Medicaid if it has a 35% drop. And then on top of it, you will actually have a self-fulfilling prophecy for many of the visions that Republicans currently have about Medicaid. And that is that we have too many able-bodied people on Medicaid that don't have to be on Medicaid. That will be true should the House and Senate plans pass, because what is going to happen is all of these providers are going to have no choice but to lay off nurses, physicians, accountants, orderlies, clerks, custodians, and any other type of person that you can imagine that works for one of these Medicare healthcare providers. So as a result of being laid off, that person will eventually, and their family, will eventually qualify for unemployment insurance, temporary assistance to needy families. Perhaps the child might qualify for children's health insurance programs, or even the family might qualify for Medicaid. Next slide, please. So I think this goes into, in general, we've basically discussed with one exception, and that is, of course, when we have these massive cuts, there'll be even an additional strain on family caregivers. And I even say here there'll be a likely increase in people in nursing homes, but best of luck again in finding that nursing home. One of the disturbing studies that I've actually seen was by the Centers for Budget and Policy Priorities, Bob Greenstein's brilliant policy shop in town, where they took a look at daycare centers. Daycare was a key benefit under welfare, under the Aid to Families with Dependent Children, which became the Temporary Assistance for Needy Families program, TANF. And because TANF was block granted under during the Clinton years, actually, in 1996, we actually ended up with daycare rates. This is daycare. That's, I mean, no offense to daycare providers. I hope I'm not offending anyone on this call who's a daycare provider. I don't think any of you are. But, daycare is a lot less complex and a lot cheaper than nursing home care. Daycare providers aggressively got out of the TANF program as contractors. So if you are a struggling mom or dad trying to find a job, best of luck finding a job that is going to be convenient to where a daycare center is right now, and is actually dictated where people are able to work or if they're able to work. It's had this boomerang effect. We fear it's going to be the same with nursing homes versus grandma or grandpa staying on your couch. Next slide, please. Okay, so we talked about these threats. In the House bill itself, the House bill, the American Health Care Act, which passed by the slimmest of margins of just 2 votes back on May the 4th, gave states the options of block grants or capping Medicaid. It cuts the program, this is according to the Congressional Budget Office, by 25% over a 10-year period. And again, it passed the House by the thinnest of margins. Next slide, please. Over in the Senate, again, the BICRA, at least the versions we've seen, gives the states the options of block grants or capping Medicaid. It cuts the programs over the first 10 years, it cuts Medicaid by 26%. Over a 20-year period, it cuts the program by 35%. And that is exactly when the boomers begin to turn 90 years of age. Now, it does this by lowering that rate of growth, lowering the amount of money that will go to the states and then, of course, be allocated to providers of care that are contracted out by the state themselves. So the stakes really are that high, or in this case, that disturbing when it comes to the cuts that we are looking at. We are not investing any of this money that is being cut, let me be very clear with you all, in any type of long-term care insurance program or reinsurance program or even tax credits to buy long-term care insurance or annuities or anything like that. There is no public or private long-term care initiative that is going in lieu of this. We're just simply cutting the program. Best of luck trying to find a provider who will take your parent or grandparent. Next slide, please. So we just don't go up there as the organization of no. We go up there with ideas to really try and focus on centrist, pragmatic, and collaborative reform for the Medicaid program. True reform. And it's worth noting, by the way, there was a great article last week in Modern Healthcare authored by Andy Slavitt, who was the administrator of the Centers for Medicare and Medicaid Services under President Obama, and Gail Walensky, who was the administrator for George H.W. Bush of the Centers for Medicare and Medicaid, that's called HCMA. And it basically said, leave Medicaid reform out of the repeal efforts to the ACA. Just let it go separately, and let's have a grown-up collaborative discussion about it, not just a fire sale over the program. And these are some of the ideas that, Gail serves on actually on our Health and Long-Term Care Committee here. But these are the things that are really widely accepted in the Medicaid reform community, to rebalance the program, to fund home and community-based services without a waiver. Let's make this law to promote more telehealth initiatives and health information technology. I know that this is a very important issue for the GIA, given their emphasis over the past year or two on rural health, but make no mistake, this is a major issue also for urban and suburban providers as well. And then I think, there's some, if you will, good governance that needs to occur that would be fairly easy to implement, such as care coordination and integration, the promotion of prevention and other types of best case practices, expanding the hospice benefit, and also promoting and expanding ways of offering the family caregiver respite care. They really are the unsung heroes, in my opinion, of long-term care. Next slide, please. So where are we at now? What's the future hold as I wind down here? First of all, we are looking at a repeal and delay vote of next week, where the Affordable Care Act will be repealed. It will take 2 years to wind it down and disappear. That vote, I don't necessarily see a discernible pathway for its passage, given that Mr. McConnell can only afford to lose 2 votes. He's already lost 3, with a 4th, Mr. Portman, saying that he would likely vote against the measure. I would imagine to be a lot more. There's only about 10 or 15 Republicans on the record for an outright repeal. There's also some missteps that the Obama administration took, which could now come back and haunt the Affordable Care Act. One of them was that the HHS secretary has tremendous power. And among the power that he or she has, in this case, Dr. Price, is to destabilize the insurance exchanges by taking away monies that insurance companies get for pre-existing conditions, so subsidies. So if I'm an insurance company and I want to subsidize the pre-existing condition that people have on my exchanges, I can do so, but the government is going to help subsidize that for me. Tom Price could take a look at insurance companies next month and say, your subsidies are ending, have a nice day. If that is the case, you will literally see the prophesizing that Trump has been talking about now for the better part of the year, and that is a death spiral of these exchanges. So Congress would literally have to have some type of stabilization legislation that would occur to prop up those exchanges. Or you would see a great deal of issues within those exchanges. They would basically collapse the individual insurance market, and they might have chilling effects on the group health insurance market, that is the employer market, and also ancillary effects on Medicare and Medicaid. Lastly, I nicknamed it here the chip dip, and that is where in the end of September, the Children's Health Insurance Program runs out of money on September 30th. Might they get a bridge, like a bridge loan, for some more money over the next couple of months? They might, but we need to address the funding of the CHIP program. How does that affect GIA members? It affects you in that that will lead to another opportunity either for a health reform discussion / possible law, or extenders, such as the Medicare therapy cap extenders, something that we care deeply about now. There is a law on the books, it's a crazy law, we have no time to get into it, where the Medicare physical therapy and occupational therapy benefit, you only get $2,000 by law for that benefit. It is capped at $2 grand a year. That law, because of JFNA and many other groups, has been under a moratoria. That moratoria expires as of December 31. We hopefully will get to that, Congress will get to that, by the end of September. We want to ensure that that moratoria stays in place so that older adults have physical therapy and occupational therapy. Next slide, please. Again, just harkening back to how healthcare worked prior and how, to some extent, it still does. We need to always keep in mind not only financing, but how reimbursement is going to work, and what the bigger picture here is. Particularly, I should mention, one of our fervent beliefs, and we hope this will be manifested by an accountable care organization. How do we convert from a sickness model in this nation to a wellness model? And that arguably might be your answer for cost containment. Next slide, please. So very briefly, as we wrap up here, let's take some action if we can and if we're able. We have our 2 leaders of the Senate Finance Committee, Orrin Hatch, the chair, Ranking Member Wyden, Chair Greg Walden of Oregon of the House Energy and Commerce Committee, and Ranking Member Frank Pallone. These are some top figures on healthcare. If there is any type of healthcare legislation, these are going to be 4 key figures outside of Mr. Ryan and Mr. McConnell that you're going to want to interact with. Next slide, please. What are some simple things to do? I think the key thing that we all can do, and here's a misnomer for foundations. Foundations believe that they cannot advocate. Everybody can advocate. Most of you are probably C3 organizations, but I would urge you, it is completely legit and legal for you to advocate, because advocacy is all about education. Advocacy is all about engagement. You probably cannot endorse, that's what a C4 does. So you can stay away from endorsing political candidates, but you certainly can educate, engage, and empower them, and have compelling messages. And certainly you don't have to come to DC to do it. In fact, don't. A more efficient way to do it and get more of your board members to go with you is to go to their district office or their state office. Next slide, please. Just one of my favorite quotes. There are those who look at things the way they are. This is from Robert Francis Kennedy, and he said this right before he died. There are those who look at things the way they are and ask why. I dream of things that never were and ask why not. I think that we still hold that truth dear, particularly now regarding long-term care, delivery, and financing reform. And then, if we will, perhaps our next slide after this. This is kind of where things are right now. Yes, it's a very tongue-in-cheek slide. Here's Leader McConnell, and he says here, and I would have gotten away with it too if it weren't for you meddling Democrats, conservatives, moderates, the Congressional Budget Office report, insurance companies, common decency. Let's all come together, as John McCain said 2 days ago when he was recuperating from his own very serious surgery. Let's have public hearings. Let's have a dialogue. Let's engage both parties on what really should be a bipartisan issue, and that is health care. John, I thank you so much for the opportunity to present, and I do hope that we have some time now for some questions.
We do indeed. And thank you so much. As always, a very insightful and wide-ranging talk. This is a field where everything's connected to everything else, and that makes it complicated, but also essential to understand those pieces. So once again, remember that you can enter your questions as you would like. There's a box on your screen. If you just open the question box and type them in, you can do that. But let me start with a couple that I'll kind of put together, but address some of these last issues. So where do we go from here? Clearly, we can't just say, well, gosh, we missed the speeding bullet and now we can rest. But what do you see between now and the end of the year as likely to happen? Is it going to be the scenario that some people talk about, which is we're going to move away from healthcare now, it didn't work, no reason to beat the dead horse, or are we going to continue to see various plans come up around healthcare?
Well, let me unburden myself and tell you my fear first, John, and then I guess we can get to my fear could come true, and then I guess we can get to some other areas here, some other pathways of action. My fear is that somehow, some way, and this is increasingly doubtful this could occur, but it could very well occur. We have a kick the can scenario, and that is where Mr. McConnell, Mr. Ryan, basically say we know to the class of 2018, that's the senators up for election in 2018, or even those up in 2020, we know that these cuts are weighing heavily on you. So we're going to remove any and all of these cuts. In fact, we're going to remove any and all cuts up until the year 2025. And that year, that's the year all the cuts go into effect. So forget about your governors. They're all going to be gone by then. They're all term limited. And you even might be gone by then. So let's just kick the can. And frankly, most importantly than any of that, we might be able to find a way to even delay the cuts further. So what do you say to that? That's a scenario that we are constantly worried about, that a future version of a healthcare bill, again, kicks that can down the road. That is something that is endemic of both parties prior. I'll mention two words to you right now: Cadillac tax. That was on the financing end of the Affordable Care Act. That was a big way that we were going to finance companies that were had very complex, comprehensive health reform plans or health insurance plans. Let's tax them. That tax, which was going to adversely affect unions who despised it, that tax has now been on moratoria for years. There's no limit to what you can do for a spending cut. So that's one area. I think the other area is the pressing area, which is what I mentioned as we wound up the call, the presentation. That is, what are we going to do when we literally have a program that is running out of money? And that's the Children's Health Insurance Program. By the way, the CHIP program is a block grant. So you can easily imagine, should Medicaid be block granted one day, that we'll have the same discussion about Medicaid. Medicaid's about to run out of money. The nursing home lights are about to go off. We're going to have to, cut off kid or grandpa. That can easily happen. That's how CHIP works right now. So the CHIP program needs funding. Are we then going to see, as a result of CHIP needing money, some horse trading? Let's capitate the expansion population in Medicaid. Let's cap older adults. They are through with their contribution to society. You don't know what could occur that could be outlandish. What we do know is that unpredictability is in vogue. Pushing the envelope is in vogue. And if this is an experience that has taught me something, John, it is that politicians are very uneducated about what Medicaid does for the long-term services and supports population. They believe that if you are older and on Medicaid, somehow you have given all of your assets to your children and nefariously ended up on Medicaid, so you deserve to be cut. These are the types of canards that we together must fight.
Well, and speaking of trying to work together in a different way, I mean, given that the current proposals did not work, there is now a discussion about can we bring the two parties together in a different way. If that were to occur, what would they be working on?
Well, you know, it's interesting. There is going to have to be some type of technical fix to the Affordable Care Act. The issues that it will have, the questions that keep popping up rely on the health insurance exchanges. So there will have to be some, we hope, bipartisan fix to those exchanges. But regarding these types of issues, I think that we've had some bipartisan findings. I know for sure we've had some bipartisan findings in many of these commissions moving forward. And the thing that we are most attracted to is the accountable care organization model. This is something that Dr. McClellan started promoting about 10 years ago. There is some language already in the Affordable Care Act that relates to ACOs. There are major incentives for different providers to participate in ACOs in the way of their reimbursement rates going up. And it's a way, again, for this country to convert from a wellness model, from a sickness model to a wellness model. Insurance as we know it needs to evolve, particularly as we age. You know, the old adage that we treat our cars as Americans better than we treat our bodies is generally true. Our cars go in quarterly for oil changes. During the oil change, once you pick up your car, you're issued a multi-point inspection where you're warned about what needs to be replaced either now or in 3 months. You rarely have that type of discussion at that frequency with your own internist. So it begs the question of the insurance policy being reactive. I get sick, I go to the doctor, I get treated, I submit a claim. Those days are waning. And eventually, I believe, if we are going to be successful at this from either a acute care or long-term care position, it's going to be that the insurance company literally becomes an ACO, buys a stake in a hospital, or simply you're insured as a life by a hospital entity, which owns different physicians and different offices and different healthcare modalities, nursing homes, what have you, in that community. And that they literally are after you for prevention, for wellness, to manage you throughout your life and to get you the best in preventative care. It's going to have it's going to make you not only healthier but also contain costs moving forward and be the picture of wellness versus sickness. Because right now none of us have health insurance; we have sickness insurance. That would be my hope.
Well, let's hope that at least part of those come true. And as we've said, these are not only complicated issues, but they're interconnected issues. So you fiddle with one part of the system and another one comes apart. We're actually now to the end of our hour, so I'm going to turn to you once more and ask you for your final words of wisdom and advice that you have to give to our audience today.
Well, you know, one thing I will say is I think that we are bracing for change. I mentioned the ACO model just now, and I think one of the most fascinating dialogues to take place in the past 2 months in this country didn't happen in Washington. It happened outside Omaha, Nebraska, 2 months ago. Charlie Munger is a name that very few of us are probably familiar with, but we're all familiar with the name Warren Buffett. Buffett for years has been liberal politically. Charlie Munger, his chief operating officer, is pretty conservative. And he stood up at the Berkshire Hathaway annual meeting as a conservative Republican, and he said, I am for single payer. And there were gasps in the room. And there were gasps in the room because what Charlie said is either we're going to fix the Affordable Care Act system, we're going to fix these large programs, or we should just simply go to single payer and raise our effective tax rates because healthcare has become more of a burden to me than the corporate tax system itself. What that told me is is that Charlie Munger and Bernie Sanders make the strangest of bedfellows. And if that's the case, then real reform might be on its way. And if real reform is on its way, we have to muscle in to that reform. And what do I mean by us and muscling in? I mean that as people vested in long-term services and supports, whether we're foundations, whether we're providers, whether we're consumer groups or professional groups who care deeply and are vested in these issues, John, then we have to come out with some cohesive and strong long-term care delivery and financing ideas. Make them pragmatic, because if we don't do it now, in just a few years, it will simply be too late. So I would urge you to cultivate members of the boards of your foundation who have an interest in advocacy, who have an interest in policy, who are vested in these issues, who have something to contribute. I would urge you to cultivate relationships with your elected officials to start this dialogue. And JFNA and many other groups that I'm happy to introduce you to are happy to serve as resources for you. A lot of the data, we all know the problems. A lot of the data, a lot of the solutions is already on paper with different commissions, public, private commissions that have already been submitted their reports. We just need the action. And I think foundations are the pillars of respect in their communities. And you all have done such great work that you're respected. So I think we could make great success on those points moving forward. And again, I thank you for the opportunity to speak with you all today.
Well, thank you so much. I want to thank Jonathan Weston from the Jewish Federations of North America for his participation in today's program. We thank you and JFNA for the tremendous work that you do to make life better for older adults. I also want to thank West Health for their support of this webinar series. We will be making this presentation available to our members who wish to view it later, including both the slides and the audio. Watch for a members only email to be sent later with the rebroadcast link. Next month, we have a general webinar, which is open to everyone, on Monday, August the 14th from 2 to 3 Eastern Time. It's focused on meeting the health needs of the rural elderly, and particularly on making use of interactive data resources to improve health and target new services, with Michael Meat, the Senior Public Health Systems Researcher and Co-Director of the Newark Walsh Center for Rural Health Analysis at the University of Chicago. Please watch your inbox for the registration information. And finally, I want to thank all of you for participating in today's webinar. Have a great day.